let's define blood thinners. Let's
Mhm.
talk about the different types and when the indications for them.
There are two types of blood thinners, antiplatelet and anticoagulant. And they do different things. With antiplatelets, right now, really aspirin and Plavix or clopidogrel, which is the same medication, are kind of the mainstay, and they've been around for years and years and years. The problem is that up to 10% of people are completely resistant to aspirin. It doesn't work on you. You might as well take M&Ms. And in Plavix or clopidogrel, 25% of people,
Wow.
1 in 4 people, fully resistant. Same thing. You might as well be taking nothing, which means that one size fits all isn't good, because if we're giving people aspirin and Plavix after their procedures, you might be the 1 in 4 that it doesn't work for. In terms of the anticoagulants out there, warfarin, Xarelto, Eliquis, these are the medications that are out there. Some of you may be on them. We don't have a big resistance issue in this group. What we have in this group is we have no way of monitoring it except for warfarin, where people do INR, where they do finger stick checks. But that's a lot of work, and you have to work to keep yourself right in the right kind of space. And the issue with that is people can overshoot it and they can bleed. So what's the state of the union right now? What are we doing as doctors? Well, we're doing whatever we want is actually the answer. There's a little bit of data that's out there sort of guiding. If you do a procedure on a patient's blood vessel between their thigh and their knee, you should give them 2 antiplatelet medications. So give them aspirin and Plavix. If you do more than that, there is some data out there that says that you can give 2.5 of what's called rivaroxaban, which is Xarelto, which is a new data that came out that said, hey, you know, that it's good for these patients. But the problem in that study is if you actually take all the patients that have this disease, only 30% of them would have even been eligible to be in that study, which basically means that the study is not something that everyone would fit into. The long and short of it is, I believe we're just managing this totally wrong. All these years we've been saying, what procedure have you had? This is the blood thinner I should give you. Instead, what we should be saying is, who are you? And what procedure you had is a piece of who you are, and this is the blood thinner you should get. For example, if you and me, Kim, let's say are the same weight, are the same height, we're both women, but I smoke 2 packs of cigarettes a day, you smoke nothing, I have diabetes and you don't have diabetes, but we both get the same procedure, it would make no sense to give us the same medication. I'll clot off because I've got all these extra risk factors, but you don't. So what we should actually be doing is testing each of our blood and seeing what does our panel of clotting look like right now, and then treating it accordingly. Because what did I just say? We have all these blood thinners that can work on the Lego pieces, that can work on the glue. We just don't know which gun should be pulled for this particular fight.